Welcome, everybody, and thank you for joining us again. Today is sort of a part two of a two-part series. Last month, we presented some cases where patients were presenting with symptoms of dysautonomia, and we kind of looked into and found that managing dysautonomia helped them control many of their other symptoms, things like anxiety, things like mast cell activation, et cetera. And this week, we want to sort of turn it on its head and say, hey, someone's coming into your office presenting with worsening dysautonomia. Maybe they were well controlled before. Now what do we do? All of a sudden the symptoms are worse. What's on our differential diagnosis and what could be driving those symptoms beyond just, quote, an exacerbation of dysautonomia or a flare of dysautonomia?
I also want to say it's really cool to see in the chat the diverse locations for all of our attendees today. So thank you for all of you taking the time to join us.
I'm going to present a case on mast cell activation syndrome as being a possible driver, backseat driver of dysautonomia. And this is in a long COVID patient. And this is not a full case presentation. I'm just going to highlight aspects of her case that I think drive this point home. I don't have any disclosures. So this is a 58-year-old woman who presented in our clinic in March 2021. She had acute COVID in September 2020 and concerned about having long COVID. She had a very common presentation of long COVID of fatigue, activity intolerance, cognitive impairment, heart palpitations, tingling in her hands and feet, shortness of breath, poor sleep, body tremors, worsening allergies, and asthma. She was about 2 weeks before she came in to see me, she was newly diagnosed with mast cell by a local allergist and was started on mometasone, H1, H2 blockers, and a leukotriene inhibitor. Prior to this, she had been pretty healthy, had been on levothyroxine. That was the only thing. So I separated out her dysautonomia symptoms and her MCAS symptoms just to for ease, and also to show sort of how they can also overlap, which can make it a little bit trickier sometimes to identify MCAS. I think dysautonomia is always a little clearer, and MCAS is something that I think hides and can emerge if you look more closely for it. Her dysautonomia symptoms were orthostatic intolerance on sitting, standing, and walking, lightheaded, dizzy, intermittent tachycardia, shortness of breath, muscle weakness, brain fog. She also had low GI motility and abdominal bloating and early satiety, sensory sensitivities to light and sound, numbness, tingling of hands and feet, dry eyes, and poor sleep that she'd never had a problem with sleep before. Her MCAS symptoms, I separated these out into body systems because this is how I screen for MCAS. I will ask patients based on body systems what kind of MCAS symptoms they might have, because one of the features of MCAS is that you have 2 or more body systems that are affected with MCAS kinds of symptoms. So this to me is a really easy way to quickly screen somebody. So for her specifically, upper respiratory, she had itchy eyes, head congestion, postnasal drip, and watery eyes. Lower respiratory, some shortness of breath, it's exertion, and her asthma had become more she had asthma prior to COVID, but had been very, very benign and hadn't actually flared for 5 years, and now it was flaring all the time. Diarrhea, heartburn, lots of food sensitivities, which to me is a major red flag for MCAS, along with drug sensitivities. Generalized pruritus, which is what had driven her to the allergist a couple of weeks prior. Cognitive impairment, headaches, particularly occipital kinds of headaches, tachycardia, which I know can be very similar to dysautonomia, but sometimes it's actually MCAS that's driving the tachycardia and not as much the dysautonomia, or the MCAS is worsening the dysautonomia to cause tachycardia to become more of an issue. And intermittent low lymphadenopathy, sore throat, and low-grade fevers. So that to me is also another red flag. If somebody's complaining of these that come and go, that's another reason to consider MCAS as part of your differential. On her physical exam, it was pretty unremarkable. She had some hammer toes on both feet that were not rheumatologically based. She does have, on her 10-minute Nasoline test, she had a mild hypertensive response to standing, but she didn't have tachycardia on standing. But she had had an event monitor prior, where a 7-day event monitor where she had 19 patient activated transmissions with OI symptoms showing sinus tachycardia of up in the 120s. So I do think she has POTS. So I'm going to highlight 3 main events that she had that happened to her since I started seeing her. It was about a year later, actually. She had actually gotten quite a bit better. Her allergist had started her on some liquid cromolyn, also known as gastrocrom. And she had been doing well. She was actually back in the office working in a busy legal firm. And she got really busy with a case and kept forgetting to take her cromolyn. And then she decided, well, I can do without it, so stopped taking it. She did okay for a couple of weeks and then had significant head congestion, sinus congestion, fever, itchy eyes, lightheadedness, dizziness, fatigue, and brain fog. She felt pretty sick. She did a number of COVID tests, which were negative. She started her cromolyn about 3 to 4 days later. Her symptoms started to abate, and she was pretty much back to baseline 10 days later. But, you can see here that she definitely had OI symptoms flare during this. Then in August 2022, she continued to improve her function and started to exercise more and tolerate exercise more. And she overexerted in August 2022 on her treadmill. And 2 days later, she developed diarrhea and mild headaches, runny nose, postnasal drips, sneezing, sore throat, low-grade fever, increased generalized itching, worsening fatigue and OI symptoms, COVID testing negative again. She rested for a couple days in bed and then started to improve. This time it didn't involve her stopping medications, but it did really start to highlight that overexertion was a big part of her, was one of her major triggers for MCAS. Then the last major flare she had was in March 2023. She had done very well from August to March, almost feeling back to her pre-COVID self, which is always wonderful to see in these patients. Pretty much all of her dysautonomia symptoms had resolved, had normal cognition. Her main inhibitor was not being able to exercise like she wanted to exercise. It would just cause her MCAS to flare a little bit. But she was doing well enough. She felt like I can go without my medicines. So she decided to wean off of all of her MCAS medicines. And this is what she was on at the time. You can see that her cromolyn had actually been brought up to a pretty high dose of 200 milligrams 4 times a day. And she was on a high dose of H2 blockers. About 4 weeks into this wean, she developed severe reflux, significant congestion, sneezing, and itching all over her body. Then her dysautonomia flared and her tachycardia increased even at night. Anxiety worsened, dizziness, and disequilibrium, and she went into a pretty significant post-exertional malaise crash. She resumed all of her MCAS medicines, and it took about 2 weeks for the MCAS symptoms to resolve, but her dysautonomia persisted. It basically took her probably about a couple of months to pretty much come out of this crash and feel like she had recovered. So it really set her back. I saw her back in May 2023, and she still was having some mild dysautonomia symptoms that were pretty well controlled with sodium and water. She did not tolerate much in the way of sodium because of fluid retention. So we always had to gently work with sodium, but she had found the LMNT to work pretty well for her. Her MCAS symptoms are well controlled. She was back to exercising, and she'd feel some MCAS flaring at the end of the week after a long week at work. But if she would rest over the weekend, she would be fine. I did start her on dextromethorphan at that time to see if we could provide her a little more baseline for managing her sympathetic overdrive. And that made a difference. It kind of stabilized her baseline better. I just saw her back a couple of days ago, and I'd also seen her in September. And her MCAS symptoms have been a little more challenging. They've been waxing and waning. Overexertion is a big trigger, and that's something that she and I spent quite a bit of time talking about. Now she gets hives, unfortunately, and she always notices that when her MCAS flares, then she feels her OI symptoms flaring. We spent a lot of time talking about how to recognize different MCAS triggers, and she definitely could identify that overexertion, foods, weather changes, viral illnesses, poor sleep, and emotional exertion were big triggers for her. We also talked about early signs of MCAS as to understand that when you start feeling that cold come on, maybe it's actually not a cold, but it may be your mast cell flaring. So to pay attention to that as a possibility. So her present treatment regimen is H1 and H2 blockers, a leukotriene inhibitor. We're back on the two ampules of liquid cromolyn, albuterol inhaler every once in a while, and she's actually on a very strict low histamine diet, which makes a huge difference for her. Her dysautonomia regimen is really light, and I recognize this. She's quite medication adverse, so it's been really hard for me to convince her to take anything. But we spent some time talking just on Tuesday about maybe adding some clonidine to her picture to see if that might help settle some sympathetic symptoms as well. Levothyroxine, CPAP, and then pacing and light exercise, which is what she can now do, about 20 minutes of walking a day, which is great. So the last couple of slides I wanted to show you are not specific to her. Before I started working at the Bateman Horne Center, I was a primary care provider, and frankly, I'd never heard of mast cell activation syndrome. And so I've been on the steep learning curve of understanding this illness. And I felt that I wanted to just, for those of you who maybe don't know much about it or haven't ever heard of it, just to provide you with a couple slides that I think present it very quickly. And it's MCAS 101, basically. Probably one most important thing is how you screen for it. I've already talked about screening with body systems, but this is from a great article from the International Journal of Infectious Disease, which is a paper about how COVID-19 and the hyperinflammation of COVID-19 is probably rooted in mast cell activation syndrome, particularly in long COVID. So this is these are all the possible types of symptoms you might see in the various body systems that might increase your suspicion that mast cell is playing a role. And remember, you need 2 or more of these body systems to be positive to consider mast cell activation syndrome. There is laboratory diagnosis for mast cell activation syndrome and includes serum tryptase, serum histamine. You can do biopsy of the GI tissue. You can also get 24-hour urines for N-methylhistamine, prostaglandin, and leukotriene. The challenge with these is that they're frequently falsely negative. And we don't do these all the time because we really have found that by just doing a symptom screen and also doing empiric trials of therapy really tell us a lot. And if they're responding well to empiric trials of MCAS therapy, they probably have MCAS. So while it may be controversial to say this, relying on laboratory data alone you're probably going to miss a lot of MCAS. This is a good example of how widespread the mast cell activation hypersensitivity triggers can be. If you have significant mast cell, it's hard to live in this world. Everything from sunlight to weather to smells to exercise to sudden changes in temperature can trigger mast cell activation syndrome. So it can be really challenging for these people. These are some of the standard mast cell therapies I see. By no means there are probably other ones out there that I'm not aware of. You can use your non-sedating histamine 1 blockers, your histamine 2 blocker, which is 1, which makes that easy. You have the one that I see primarily used is cromolyn or liquid cromolyn, also known as gastrocrom. This is covered by insurance. We also use compounded medications, ketotifen and cromolyn capsules. Ketotifen is a mast cell stabilizer with an H1 in it, histamine 1 blocker as well. I like this one a lot, particularly if you've had a lot of drug sensitivities. I find that people can sometimes start on ketotifen and then move to the gastrocrom and tolerate it better. Cromolyn capsules, I think one of the things that make these great is they don't have preservatives in them. So people can sometimes, if they're sensitive, will not react to any kind of preservative. But they're particularly good if they have occipital headaches and dermatologic symptoms. Low inflammatory, low histamine diets are super important, so it needs to be a big part of your teaching with patients. Diamine oxidase is a supplement that can work to help break down histamines in foods. Then there's montelukast and steroid inhalers. And lastly, just a few clinical pearls. MCAS is frequently playing a much larger role in post-viral syndromes than you'd think. So screen for MCAS initially and frequently. Suspect MCAS if OI treatments are not making a difference, or if a person has a lot of medication sensitivities. When you initiate medication, start on low dose and increase slowly. This can really help lessen reactions. Some MCAS and dysautonomia symptoms overlap, making it challenging and to sometimes distinguish between one or the other, and understanding that MCAS can sometimes be a major driver. I've already mentioned something about the screening labs. I rely on your clinical picture and response to therapy, empiric therapy. That's going to give you a better idea of what's going on. H1, H2 blockers are considered the starting point for therapy. However, if I have a severely affected patient, I increasingly start with mast cell stabilizers. Mast cell stabilizers result in histamine release, but they also result in about 150 other mediators causing MCAS symptoms. So why not start at the source? And diet can play a big role, so make sure you counsel on low inflammatory or low histamine diets. And that is all I have.
Great presentation. Good thing to review for sure. With your patient, did they mention why they wanted to wean off medications? I'm not aware that mast cell activation syndrome is not one of those things you sort of get over that I'm aware of. I mean, I know the course can be variable, but if they mentioned why they wanted to go off, or was a medication concern, or I get a lot of people that don't want to quote beyond medications, which is an interesting one. And as I'm like, you wouldn't tell a type 1 diabetic just to see if they can wean off their insulin. They're just moments where I'm like, what are you doing? So I'm curious what their motivation was on that one.
Their motivation was to not be on medicines. That was it. And she, as I said, she was really medication adverse. And so she's been, I always have to give her time to think about starting a new medicine. And I think it's also, goes back to education and educating the patient that, this isn't something you just get over. But I think with a lot of these long COVID patients who were well before, and now they're feeling better on their medicines, are like, well, then I'm better. I don't need them anymore. And so I think it's a bit of a process for people who were well and now they're not. So that was the main reason.
Dr. Brown, I've seen a lot of my patients to come to me and say, I'm coming in with fatigue and I'm unable to go to work and I'm dizzy and I have palpitations. Why are you worried about my runny nose? Why are you worried about my rashes? That's not my biggest concern. And it's sometimes hard to make that leap with the patient to say, actually, if we get these under control, those histamine-based symptoms, those are a harbinger for what's going on, but that's not the whole problem. We're not treating allergy symptoms. We know that mast cells playing a big role in driving those other factors that you really are struggling with. And if we get that aspect of things controlled, we've removed some variables. Now we can focus on what remains and really get that therapy titrated.
It can also be helpful sometimes too for patients to believe us that these are, like what you just said was true. And so sometimes if they do their own experiment when they go off their meds and they're like, oops, that didn't work, and they go back on them, it's sort of a proof of principle for them. But I still think there's this weird thing in our society that like some sort of sign of weakness, God forbid you have to take a medication. And I'm like, better living through pharmacology. Let's not go back to the dark ages.
Thank you. Really great points. Dr. Hoppers is back with us, so we're going to give this another shot.
So my topic today is ME/CFS and post-exertional malaise. So this is a 29-year-old patient with a history of ME/CFS since the age of 17. She has had waxing and waning of symptoms throughout her illness, but has had a fairly steady state for the past year. Her comorbidities include POTS, MCAS, small fiber neuropathy, hypermobile spectrum disorder, chronic migraines, fibromyalgia, TMJ, GI issues, brain fog when fatigued, and insomnia and restless sleep. HUA is hours of upright activity. It is time spent with feet on the floor, whether sitting, standing, or walking in a 24-hour period. Normal, healthy people have a HUA of around 12 to 16 hours in a 24-hour day. Okay. My patient had an average HUA of 7 hours in a 24-hour period. She attends school 4 days a week and rests and recovers 3 days a week. She has 16 good days a month where she gets dressed and drives. She attends school and prepares simple meals. She can't exercise or do significant upright activities after school, and her HUA on a good day is 10. On her bad day, she can rest and spends most of the day in a recliner and studies. She does a load of laundry and has groceries delivered. She states that she has increased fatigue and general malaise on these days with a HUA of 3. In looking at this, it's really helpful for me if I have, if every time I see a patient, I get their HUA and their good days and bad days. This information is really helpful because if you just look at her on the surface, she is going to school, she comes to her appointments alone, she lives independently, but really she's not doing well at all. She's in a chronic push-crash cycle. She works all week, pushes and gets through the week, and then just basically crashes on the weekend. Also by getting this information, I was able to see that her HUA had decreased from 8 hours to 7 over the last couple of visits. She was having increased absences and leaving early from school. We discussed pacing, discussed accommodations. I was really quite concerned about her, but she had a couple of weeks left of school and she was in grad school and she really didn't want to pause the semester and start back over. So she planned to continue with the plans to rest as soon as she got through with school. Currently, the patient at that time was on midodrine and propranolol for POTS. She took loratadine, famotidine, compounded cromolyn, and LDN for MCAS. For small fiber neuropathy and pain, she took baclofen at bedtime, pregabalin 75 twice a day. The LDN helps this as well. She was on a supplement for cognitive impairment that had luteolin, rutin, quercetin, and palm olive oil. And for her autonomic overdrive, she took propranolol. For insomnia, she took trazodone, melatonin, and diazepam PRN. She took it about once or twice a month. For her GI issues, she consumed a healthy diet and diamine oxidase before meals. So at this point, just a kind of a summary of where her baseline was, she was functional. She was independent, but clearly kind of living on the edge, as I would put it. Again, we talked about pacing, talked about, repercussions of chronic PEM or PEM, but she went ahead and went on with school. So about 2 months later, I got an urgent call. Mom asked if I could see her urgently. She had been declining since the last two-month visit. So good to go. So basically what had happened is that after her last visit, she went ahead, finished school. It was about 3 weeks. She had increased activities because it was graduation. I don't know if she had exams, but she just had a more rigorous schedule. And she said that at the end of that, basically the next day, about 24 hours later, she just felt terrible. She couldn't do much of anything. She had aches, increased symptoms, increased orthostatic intolerance, just worsening of all her symptoms. So she rested for 2 or 3 weeks. She improved a little bit, had a HUA of 4, but she had a pre-planned family vacation and felt like she wanted to go. So she did. She had a day of travel. She went, she was in an airport, so she had all of the triggers. She had sensory, cognitive and physical stressors on that trip. Once she got there, about 24 hours after she arrived, she ended up in the bed. So she spent most of her vacation in the bed or in the hotel reclining, and would go sometimes out in the evening to dinner with her family. So then, still feeling pretty rough, she had to travel back home. And she said by the time that she got home, she just was in a terrible state. She hurt from head to toe, could barely walk, and just went home with her mother. And so she stayed there for the next 3 weeks, said she really didn't do much of anything, but she had a HUA of about 1 or 2. And then graduation, it was time for graduation. So I don't know how she did it, but in that condition, she got up, went to graduation. It was an hour and a half away, so she had to travel, spent the however long it takes to graduate and come back. And so when she came back the next day, she got up to take a shower and she ended up falling in the shower and she couldn't ambulate unassisted at that point. So this is where I saw her. She was in a wheelchair when I went in the room. Her pulse was 90 in the wheelchair. When we assisted her to stand to sit on the exam table, it was 136. Her BP was 110/70. She just appeared really tired, just looked really different from her last visit. She had dilated pupils of 7 millimeters, small, tender anterior cervical lymph nodes, and delayed capillary refill. Change slide. She also had tenderness at the SI joints and over her muscle groups, but otherwise her physical exam was really unremarkable. Change slide, please. So at this point, I really felt like she had post-exertional malaise. She had worsening of symptoms after, a big exertional event. But I did want to make sure nothing else was going on. When I look back at this case, I go, wow, nothing else could have been going on, but it seems so obvious. But at the time, I did do the workup and it was all normal. So post-exertional malaise is also known as PEM. It's the worsening of symptoms following physical, cognitive, orthostatic, emotional, and sensory stressors. It can exceed after far exceeding your threshold, but also after repeated episodes of slightly exceeding your threshold. And this patient had really done both. It can be delayed up to 72 hours after activity. It's often referred to as a crash, and new symptoms can occur at this time. Change slide, yeah. Common symptoms are exhaustion, brain fog, nausea, headaches, insomnia, sore throat, muscle and joint pain, orthostatic intolerance, flu-like symptoms, and my patient pretty much had all of those. It is a condition that is unique to ME/CFS, and PEM can cause permanent worsening. So what we did for the patient that day in the clinic, we gave her normal saline and planned to do that for 3 days each week for the next 3 weeks. I did start her on fludrocortisone, 0.1 a day, and diazepam, 5 milligrams twice a day instead of PRN, or excuse me, 5 milligrams twice a day for her sympathetic overdrive. The patient at the time wasn't really in a state to hear a lot of counseling, but I did talk to her mom about trying to help her pace and to really, I didn't want her to do anything except basic self-care and to try to just reduce her stimuli and, reduce interactions with her and that kind of thing. So she came back in 4 weeks. On this day, she was able to walk into the clinic. We have a little side door, so she doesn't have to go far, but she was able to do that. She reported a HUA of 1 hour. She said that all days are bad days and had minimal improvement. She could read a little bit more than she could before, but basically her symptoms of orthostatic intolerance were still present with any exertion at all, and she continued to struggle with all of her symptoms. And this is in the red is a lean test that I did about 6 months ago. She was on her meds and she had no fluid or salt restrictions when we did the test. So I was doing that because I kind of wanted to see how she was doing. At the time she reported she was feeling about as good as she had ever felt. And then that day in the clinic, when the second visit in the black are her vital signs, I just did orthostatics that day. So you can see in the black, that day, her heart rate went up 35 beats per minute. Her pulse pressure reduced by 6 in the first minute. But if you look at her lean test from 6 months ago, her heart rate in that first minute just went from 66 to 74. So you can see the difference in that. So clearly, I had not helped her POT symptoms at all. I increased her pyridostigmine. She had already stopped the fludrocortisone because she felt like it worsened her headaches. I did add aripiprazole 0.25 Q-day for sympathetic overdrive. This day, we were able to discuss pacing a little bit more. We talked about task analysis to break down the things that she was doing into small pieces. For instance, brushing her teeth, breaking that down into pieces, walking to the bathroom, rest, brush your teeth, rest, walk back, rest. But also we talked about using her heart rate to guide the need to rest. So when she came back in 8 weeks, she was a little bit better. Her HUA was up to around 2.5 hours. Overall, she felt a little bit improved, but not well. She could sit in the recliner and watch TV, which is what she did most of the day, but she was able to get dressed. She would occasionally eat a meal with her family, but she continued to have problems with orthostatic intolerance and shortness of breath with much exertion. And overall symptoms, again, were a little bit improved, but she was still struggling with them. Again, I increased her pyridostigmine, I increased her aripiprazole, and at this point, the patient wanted to decrease the diazepam, so we did that. we talked more about pacing, and she was using her heart rate to pace her activities. And she told me that basically that meant she could do not much of anything. So, but that's what I wanted her to do. So at 12 weeks, she came in, and this is just a comparison. Before all of this, she lived independently, had a HUA of 7, was able to prepare her own meals and go to school. After this episode, her HUA was 3, and she did not live independently. She was doing a few more things, as you can see, but all of those things weren't done in one day. So, and this is just a little slide that shows you that the blue dots are her hours of upright activity, and the line is just time. You see the decline is over 12 weeks, and you can see how fast that happened. And then as she's starting to improve a little bit, you can see how much slower it takes to improve. So at the end of the day, what I got from this, and especially going back and looking at it and being critical of everything, the treatment for PEM is prevention. You know, once it's there, it's really, really hard to control. And I really am not sure that anything I did made much of a difference other than really getting the point across about pacing. I try to introduce it. I was trying to do that before, but really after with this patient, it's really made me a little more attuned to making sure that every single patient hears at least something about pacing at every visit, especially that first visit. Trying to give them resources ahead of time when they are not in PEM so that they can prepare. Talking to them about frequent breaks, setting timers during activities. So, you need the breaks, but sometimes you keep going, you just don't think about it. So setting timers are really good. My family is affected by ME/CFS, and I've done that a lot. I have to do that because the I don't know, hope springs eternal, I guess. And you think, wow, we're having a great day, and you keep going and just, kick yourself afterward if you don't stop. So it's really good to have timers. Heart rate monitoring, you can have them, use their wearables and see what their average resting heart rate is, and add 15 to 20 beats per minute to that, and then use that number as an alarm on their wearable to tell them when they're getting to that number and they need to rest. You can also modify activities, use a shower chair, handicap placard, delivery services, that kind of thing. I try to talk to people about that early as well, because you're right, in this long COVID population, especially, they really, they go from perfectly healthy to me talking to them about a handicap placard. That's pretty hard to hear. So if you kind of start early, and just sometimes I say, I'm just telling you this so, you can think about it for the future, but just try to get, and I always tell them, look, you can walk through the parking lot of Target, or you can spend that, 3 minutes having a conversation with someone in your family on the telephone. So it's all about choices. Reducing stimulation in the environment with earplugs, sunglasses, that kind of thing. Also, I think invaluable is a PT and OT who is knowledgeable about ME/CFS and PEM. I know I've learned so much from the people associated with the Bateman Horne Center in occupational therapy and physical therapy, and they're wonderful. We don't have that in our area, so I am the de facto OT and PT.
Thank you, Dr. Hoppers. I think that was a really excellent way to show that post-exertional malaise is an altered physiological state. This is a different metabolic state. This is a different part of their illness, and things behave completely differently during that time. And it's a reminder, too, that while we may attempt or really feel the need to throw a bunch of medications or other interventions at it, people are coming in, they're a lot worse, they're urgent, what do I do? And it's not always about what you try during that time, but sort of the quicker you can surrender to PEM, the quicker you can allow yourself to heal from what is essentially a physiological injury, the quicker you're actually going to get out of it. And it's only when you're not in PEM that all of those interventions, pharmacologically and otherwise, really can help people. When you throw that at them during PEM, it's hard to see those responses. So many times I've tried to use medications and later realized, yeah, the patient was in a crash. They weren't responding. They had headaches. They had hypersensitive reactions to the medications. You can put those back in your tool belt and come back a few weeks later, a few months later, when they're not in post-exertional malaise, and those same therapies, those same interventions can be really helpful for them in avoiding post-exertional malaise in the future.
Thank you. Dr. Yellman, let's try to get to your vignette here, and then I do see that Clayton is answering Jessica in the chat, but we'll try to get to that for everyone to be involved in.
Okay, so we have our 37-year-old patient with ME/CFS, POTS, that was diagnosed by a 10-minute standing passive Nasoline test. She also had gastric and small intestinal dysmotility, mast cell activation syndrome, chronic recurrent headaches, and migraines. They were sort of different in their phenotypes. Had been diagnosed with hypermobile EDS and a post-herpetic neuralgia. And she came into a follow-up visit in my clinic with a sudden and dramatic reduction in her function with notable symptom increase. And this was right after she caught a viral gastroenteritis from her husband. He worked as a teacher in an elementary school, so he was always bringing back fun things for their family to enjoy. She had had several episodes of forceful, urgent emesis with this initial infection, pretty powerful, as she recalled. In her symptoms, she was now a month out from the initial infection, and her symptoms had persisted for over a month, even though she had actually recovered from that viral gastroenteritis. She had been previously enjoying approximately 3 hours of upright activity with her feet on the ground per day, and maybe 8 hours or so of cognitive clarity and ability to enjoy and interact with life. She did a lot of that from a recliner chair with her legs elevated, but did feel she had some quality of life at that point. But now she was tolerating less than 10 minutes of upright activity, and she was essentially back and forth to the restroom for that upright activity. And she only spent about 1 to 2 hours of time total in that recliner, most of which was spent sleeping or in pain with her eyes closed, keeping the lights down, and being disengaged from her surroundings. She was experiencing persistent headache and head pressure, where the focal point of discomfort was actually at the base of her skull and then above her left eye. And this was similar in phenotype to one of her two usual chronic headaches, but this headache was much more persistent. It didn't wax and wane, and it was quite a bit more intense than the previous headaches she had had. The other thing is that it did not improve with acetaminophen, ibuprofen, tramadol, or diphenhydramine, which were tools she generally reached for when these headaches would bother her. She was also reporting significant dizziness, palpitations, leg weakness and tremors, especially when trying to walk, and feelings of near syncope with even mild orthostatic challenges. And this reminded her of her symptoms when she initially presented to our clinic prior to initiating any therapies whatsoever for ME/CFS. She also had minimal appetite with significant anorexia, early satiety, nausea, bloating, and very minimal food or even oral water or salt intake. And her mental status and overall degree of pain did not remind her of her usual prodrome of post-exertional malaise. So unlike the case that we just heard from Dr. Hoppers, she said, though some of my symptoms are quite a bit worse, I'm not having the same type of brain fog and mental symptoms I would have with PEM. This feels really different. It's bad, but it doesn't feel like my PEM. Her vitals, she was afebrile. Her blood pressure was elevated 158/88 when she usually averaged somewhere about 112/72. Her pulse was increased to 94, respirations were 12, and she was satting 98% on room air. She had a normal complete metabolic panel, CBC, low inflammatory markers with an ESR and CRP, and her TSH was within normal limits. And she did actually undergo a stool viral PCR that was negative, stool O&P that was negative, and her fecal calprotectin was low. So we didn't think there was a persistent gastroenteritis or GI infection or other GI inflammatory process at this point, despite her continuation of symptoms. Her pharmacotherapy at that time was as follows. She was on pyridostigmine and midodrine, specifically to help her with her orthostatic intolerance. She used Gastrocrom, or the liquid cromolyn we talked about with Jennifer Bell, 15 minutes before meals and medications, in addition to a compounded capsule of cromolyn sodium 3 times a day. This was supplemented by montelukast as well. She would use Adderall, 10 milligrams ER most days to try to stay awake and engaged while she was there in that reclining chair. 3 milligrams of low-dose naltrexone, 1 milligram of aripiprazole. She used Emgality and Nurtec for migraines, as well as amitriptyline, and then a little bit of fluoxetine for mood-based symptoms. So what were our clinical interventions in this case? Well, first we gave her 1.5 liters of IV normal saline. I did that 4 days in a row for 1 week, and then repeated that again a second week to help improve her intravascular volume and to try to help with the anorexia and nausea. Clearly, she was not taking in enough fluid and salt to the degree that she had been prior to this setback. Her pulse, her heart rate variability, her anorexia, and nausea all improved with the saline. But her headaches and her fatigue and her orthostatic intolerance symptoms and even her functional capacity remained essentially unchanged. So at that time, we began performing upright cervical traction. And the reason was because we were concerned that with the extreme vomiting that she, in fact, in the context of hypermobility, may have contributed to a slight neuroanatomical shift in the context of a potential craniocervical instability, an instability somewhere between C0 and C1 or C1 and C2, which was a concern we had for her before, but it hadn't ever really presented so prominently. And so in this case, we wanted to perform upright cervical traction using an Aspen Vista multipost, which is the collar that you can see here on the right. We had her put that on. You actually pull out this little yellow tab and you can twist it forward and elevate to different levels. This particular collar is good. It's got a little inflatable bladder that sits here in the back of the neck, so as to keep you in a neutral position when you lift up, as opposed to a flexed or extended position, which is really critical in this case. And we had her put herself in traction for about 5 to 15 minutes twice daily, and she would crank it up to a place where it was slightly uncomfortable but not ridiculous, and hold it there. And she was gradually increasing that traction over time as her muscles got used to it, and just as she got accustomed to the collar. We would also have her wear a soft cervical collar, similar to the one you see right here in the lower left quadrant. And this was something she would put on after her initial traction. So this is just sort of an upright cervical support if she was going to be upright. And we had her use that for about 3 to 4 hours a day. And I think the idea is there is twofold. One, if gravity is playing a role, pressing down on the head in the context of craniocervical instability, that can lead to a little bit of actual impingement on neuroanatomical areas like the brainstem. And so by sort of holding the head up for someone, you can sort of prevent that slow sinking over the course of the day as they're upright. Additionally, if you put this on right after traction, it can sort of extend the benefits of the traction. So if someone's wearing traction and they're feeling a clinical difference in it, you obviously don't want to stay in an uncomfortable position for the duration of traction, but if you can put a soft cervical collar on, it can sort of extend that halo of benefit from traction afterwards. And then later, the patient began working on isometric neck physical therapy exercises, ones that did not include rotation or movement or flexion or extension of the neck, to try to engage the deep musculature in the cervical region, and used that to sort of strengthen her ability to hold herself in these slightly new, slightly varied anatomical positions that were being mediated by the cervical traction and support. And these were our outcomes. So her headaches were immediately mitigated with the initial traction efforts and eventually resolved with more consistent repeated traction. She also noted that her mental clarity and sense of debilitating fatigue improved when she was in active cervical traction, even if the neck muscles were tight and strained and kind of uncomfortable. Her blood pressures that had been elevated actually returned to her previous lower baseline, and her orthostatic intolerance symptoms also returned to her previously pharmacologically managed baseline. And her nausea, anorexia, early satiety more consistently improved rather than temporarily with the IV fluids, as if her GI motility improved with the traction. We also found that her hours of upright activity and functional capacity returned to her previous pre-viral gastroenteritis baseline. And then actually with continued use of traction and isometric exercises on the neck, she actually saw significant benefits. In fact, she exceeded her previous baseline over the following few months as far as her functional status was concerned, so long as she remained consistent with the traction with use of the soft cervical collar. She would also wear that in vehicles, like if she was in a car and it was bouncing around, she found that not wearing a soft collar, not having cervical support could exacerbate symptoms. And by just putting on a soft collar, she could avoid that outcome. And she continued to use regular neck isometric PT exercises. So she got to a point where, in fact, her functional status improved from the pre-illness baseline quite a bit, as long as she was consistent with these measures. And every once in a while, she gets a little tired, she falls out of her routine, and symptoms start to come back. And once she returns to this sort of maintenance plan, it helps her control the entirety of her illness. So the real key teaching point here that I want people to remember is that a sudden and dramatic reduction in functional capacity, or a lack of response to therapies that used to be really effective for people, can have neuroanatomical underpinnings, and those can be craniocervical instability, atlantoaxial instability, and other neurological underpinnings. There's certainly cases of tethered cord or venous outflow tract obstruction, but certainly when there's a big change like that, did they slam on the brakes hard in a car? Did they ride a roller coaster? Did they vomit really hard or sneeze really hard? Was there a big storm that came through? Don't forget that neuroanatomical changes can be something that really swings the course of an illness.
Thank you, Dr. Yellman. I want to get to a question that is in the chat, and Jen, I'm going to turn to you since you did answer it, but I want everyone to be able to hear this. The question is, how do clinicians differentiate between MCAS and PEM since both are exacerbated by exercise and the symptoms can overlap?
So MCAS is its own set of symptoms, but PEM is, or MCAS is often presents within PEM itself, along with orthostatic intolerance. So when you overexert cognitively, physically, emotionally, sensory-wise, or orthostatic-wise, being upright for too long, you can trigger your MCAS symptoms that are maybe lying more treated at that time, but the MCAS symptoms can actually become more exacerbated. So it can be sometimes hard to tell the difference, and sometimes people's overexertion, the MCAS seems like it's the primary symptom that is involved in PEM, but kind of getting an idea of when did the overexertion happen, how long after the overexertion, or the many days of slight overexertion, like Dr. Hoppers mentioned, how long did it take for the worsening of symptoms to occur? And if it was definitely, 12 hours or so after those exertions, then you may find that, and if they persist, then I'm much more likely to think it's PEM as opposed to just an MCAS flare. But they're very intertwined, so it's not always easy to pull them apart. I hope that made sense.
Thank you. Dr. Yellman, do you want to tag in on Emily's question here in the chat, which is a question about MCAS. In the Dysautonomia International Conference, there was research presented that MCAS was the result of a smoldering, untreated infection about 50% of the time. Should infections be screened for more attentively?
Yeah, I think this is a really complicated question. Certainly, whenever there's a change in someone's baseline, we're always looking for some change in their environment, right? And so if they've been exposed to a viral gastroenteritis, if they've been exposed to a new infection of COVID-19, any kind of upper respiratory illness, it's important to understand that while the immune system is activating to essentially address that infection, it's likely also exacerbating mast cell activation. But then there's sort of the other question in our post-viral illnesses about chronic smoldering infections, right? Do we have Epstein-Barr virus reactivating? Do we have herpes simplex reactivating, HHV6, Coxsackie virus, et cetera? And I think that's where it gets a little more confusing, because we've certainly all seen cases where we recognize that symptoms from those reactivating viruses are kicking up, and we think that we're increasing antibodies, although we generally can't see a positive PCR of these supposed reactivating infections. And this will happen a lot when a patient is in post-exertional malaise. They'll start showing these symptoms of reactivating infection. And it's hard to say whether the infection is driving mast cell, whether mast cell is driving the infection, whether post-exertional malaise is allowing for viral reactivation, but you had to get to PEM first based on some other exacerbation of symptoms. So I think the jury's still out on what's the chicken and what's the egg, and we still have a lot to learn in that regard. But when it rains, it pours. There's no question about that.
Dr. Yellman, since you just did the case on CCI, there's a question here. When wondering about craniocervical instability, how useful is imaging before treatment?
That is a very large topic. In fact, there's another ECHO series coming up where I will talk specifically about that. But it's important. Craniocervical instability, this is really, we are still learning a lot about this. We're still on the frontier of understanding this entire concept. And what's become abundantly clear to me as internist by training and a rheumatologist rather than a neurosurgeon is that the functional assessment of CCI is perhaps much more important even than the imaging assessment, right? It's actually quite hard to get appropriate imaging. You need a 3T machine. You need very, very specific protocols with techs that know exactly what they're doing, and you have to position people just perfectly to really see what you're looking for when it comes to CCI. But a lot of times an empiric trial of cervical traction with the type of Aspen Vista multi-post collar that was provided, or even an empiric trial of a soft cervical collar just for upright support, saying, hey, wear this for 3 to 4 hours a day in the morning while you're on the computer for work, and see if you get an extension of your energy envelope before things really kick in and you hit the wall for the day. Those can be pretty diagnostic, and of course then therapeutic. We try to start using that to our advantage in the long run with a sort of prescribed regimen like we did for my patient there. So in general, I mean, imagine you have a patient and they get imaging and it says, yes, they have definite CCI. Well, we never want to move someone straight on to a surgical intervention like a cervical fusion, which is kind of considered the definitive therapy for this, unless they really, really need it. There's quite a bit of risk associated with that procedure, and we still could get better at that and have more surgeons doing it. And so if we can manage it conservatively with something like cervical traction, soft cervical collar, dedicated cervical physical therapy, and actually improve symptoms like we did in the patient that I suggested. She's literally been managing her symptoms for a year and a half now, just with conservative therapies. And so to me, I almost always start with the functional assessment. They're not perfect. They certainly don't catch everybody. There are people who don't respond to those measures, but I start there first. And if I am not getting anywhere with the conservative functional assessments, then I start thinking about imaging and saying, do we really have to dig deeper into this? Do we need to get neurosurgical assistance with this because this patient is just stuck and there's no way to move it? So I kind of think of it in a reverse order there, but I'm sure that I may change on that as we continue to learn more about this field.
Thank you. We packed in a lot today, and I appreciate everyone being so kind and understanding. As we all know, technology sometimes runs how things go, but we all bounced back, and I think that it ended up going pretty well. Just a reminder, we do have another echo session for the year that will be on December 7th, and it ties in pretty nicely to a lot of the things that we've been discussing so far. So we'll be hearing from DPT Clayton Cowers and OTR Amy Mooney. I think that it's going to be a really important session for all of us to join, because really when we're thinking about long COVID and we're thinking about this post-viral world and ME/CFS, so often we refer to rehabilitative professionals. And I think that what they have to share with us and some insights on how best to go about teaching pacing and helping these individuals live within their lives, this new life that they have, is so important, because that really can shape how well they do. So I look forward to hearing from them on December 7th. As a reminder, claim your CME by midnight tonight. And it was so good to see you all. Thank you.